both. We'll do the women talk first, and then we'll do the man talk second. Probably because the men's talk, like men are, is much more straightforward. It's easy. You get through it. It's cut and dry. You know,
just how they are.
So the women are more complicated. So, like, we start out with these questions. So you may look at these questions, and you may find that you're answering yes to a bunch of these. And actually, as a man, you may be answering because the question list for the men is very similar. So as things start to decline, and some of this you might say is aging, but some of this is pathologic aging. So it's not normal. And sometimes doctors will say, well, you know, you're just kind of getting that age, and oftentimes they'll say that when they have nothing else to say, and you know that really grates me because that's not always the case. You know, there's much more of this that we can control than what we think sometimes. So we shouldn't just accept that, and so we should go and look and see, why is this happening? So there are a number of different pathways to aging, whether it's antioxidants, it's inflammation, too much sugar in our system, free radicals, DNA damage. The one we're going to focus on today is hormonal decline. But we realize that hormonal decline actually interacts with all these other pathways of aging, and that when we're hormonally deficient, that does accelerate our rate of aging. And so that's part of our approach to anti-aging medicine, is looking for the indicators that are going to accelerate our rate of aging, accelerate our rate of disease, and prevent that from the beginning, right? So how do we minimize that? Obviously, really lifestyle, nutrition, stress management, all those things really should come first. I can't overdrive tons of bad choices in life and management and nutrition and try to make up for it with hormones. It just doesn't work that way. We've got to start from the bottom up, and including mind, body, spirit, because we're all connected that way intimately, and we've got to pay attention to all of that in our holistic approach. So what are hormones anyway? You hear a lot about that, and people don't know what they are, but they've got to have some because they make you feel good. So we'll talk about that. And then what is the controversy? And then what are the things we should think about when you're thinking about doing hormone replacement therapy? So it's really about communication. And so the way I think about this, our hardwired communication are our nerves. They go to our brain, and the nerves from our body that return signals back. So the hormonal system is like the wireless network. And so it's the messengers that are floating around, and so they go to wherever the receptors are that need to be activated or turned off based on the need, okay? And it's all controlled in the hypothalamus in the brain. So that's the central server, if you would, of this whole hormonal system. So hormones are basically biochemical messengers, and they're designed to be produced in one place and usually have their function away another part of the body. They can turn on and off functions in the body. Some people feel like they're, think of them as turning on, but they can turn on and off to regulate that. And they even regulate gene expressions. That's very important. And as we've also found, food and nutrition also are important in gene regulation and expression, and also food is important in our hormonal expression and regulation. Okay, so that's why that's very important. So our optimal hormonal levels really occur in our 20s and our 30s. And so that's when the gradual decline comes. And so we can actually start having gradual decline, but we don't have symptoms to maybe even a decade later. Then we hit something called menopause. Then we recognize menopause. Women typically have a more acute plunge into menopause, if you would. Men usually have a more gradual decline, as we'll see with that in a few minutes. Okay? So we also know that during that time, when we're at our hormonal optimal levels, that we have fewer diseases. We have fewer fractures. There's less problems going on with the body and breaking down. And once the hormone levels start to drop, we start seeing all those levels go up. So it also is it's a major ager. So it goes up. Disease goes up as we lose our hormones. Okay? And so definitely negative consequences, not only just on longevity, but on our quality of life as well. And then you think you're going down the right road, and you find yourself down the road to crazy woman. So I want to talk about a couple of terms as well, bioidentical hormones. And sometimes people confuse this with natural. So sometimes people say, well, I want to do this a natural way. Well, we know that when we look at some of the estrogens that are derived from horses' urine, that's also a natural product, but it's actually detrimental to the body. So when we talk about bioidentical, we're talking about exact copies of what your body makes, so your body can recognize it and use it within the receptors and break it down. The synthetic versions are something very different. So, and they could come from a natural source, but they're not necessarily good for you. Okay. So for years there were large studies, hundreds of thousands of patients, that showed the benefits of hormonal therapy and balancing hormones. But then around 2002, the Women's Health Initiative published a study, or that amount of 2002, 2004, and they found something completely different. That they thought that the risks were much higher, the cardiovascular risks were higher, that they maybe increased Alzheimer's, but it really didn't help like they thought. So how can that be? And that's where this whole controversy comes in. Well, as we'll see, really the controversy should be on that they use synthetics in the first place. But in that study, it may be that they got the results that you would expect given the way the study was designed and the population. Okay. So when we look at that, they came up with this study to look at hormone replacement therapy by using estrogen only or a synthetic estrogen. So they used a synthetic form of the conjugated equine estrogen, which is the horse's urine. And then they also did an arm where they put it together with a synthetic progesterone, or progestin, Provera, majoxyprogesterone. They used an older age group. They used a group of women that were mostly obese and had cardiac risk factors already. 10% already knew they had cardiovascular disease. And then they also used a group of women that weren't symptomatic in this study. So we can already see the beginnings of why would there be some problems with this study. So what they found was that this hormone replacement therapy increases risk for heart disease and stroke and breast cancer and blood clots. But it did find that it decreased the risk for osteoporosis, fractures, and actually colon cancer. So even in the face of using the synthetic, there were still some good things that came out of that. So they came across with the recommendations that the risks were too much for the benefit, that you really shouldn't use it for primary prevention, and that if you're doing it, you should use really the lowest effective dose. I agree with that. But then they said only for the shortest term possible. But we know that if you're just doing it to treat symptoms, that you're ignoring a whole host of other health benefits that you get out of hormonal balance. So even in their own study with the estrogen trial, they showed that just by doing the estrogen only, that there was actually a decreased risk of breast cancer, and it had a decreased risk of coronary artery disease, but they did have a little increased risk of stroke and DVT with this deep vein thrombosis. But they had no change in mortality, and their risk index was the same, and their hazard risk was the same. Okay, from all the big concern that they got out of that. So in reality, there were 6 more cardiac events per 10,000 in their study. And now that risk was mostly in the first year. And of course, these are older women with already known risk factors. But by the 4th year, they actually had reduced risk. And so in the studies that were prior to that, that also showed that the estrogens were protective. Well, the reason we think that is because sometimes when we give estrogen, it can actually soften the cardiovascular plaque, the cholesterol plaques, which is part of the way that it prevents it from getting there in the first place. It changes your dynamic in the plaque and also changes your cholesterol levels. So if you look at the younger women, they found that the calcium scores were lower and they had decreased cardiovascular risk if you started in the younger woman as they approached menopause. But if they had already had known disease, it could actually increase the cardiovascular events. The same is true for there's a very large study called the Nurses' Health Study that showed that if you started replacement therapy in menopause, that it was actually beneficial. And what they actually found, it was beneficial really to the level of what they call statins to be protective now for cardiovascular risk. But they don't really talk about that part. You know, that doesn't fit the sensational model that they're going after now. So we look at this in the later analysis of their own data. They had no increased risk of mortality. They had a 35% risk in hip fractures, 24 to 25% risk of other fractures, decreased diabetes, UTIs, urinary tract infections, and then even colon cancer. Wow, that's pretty impressive. But that's not what they talked about in the news with that. You know, they went with the sensational story. So we actually found that, well, okay, maybe we get the results that we would expect for that, so we know how these things work, and that we just have to take some caution. So when people have known cardiovascular disease, we got to think about that. And then assume, okay, what's the risk and benefit? Quality of life really means something. That's important. And just be careful as we approach that. But we know much of the problem has to do with this synthetic progestin. And so, and even in their own literature, they don't make the distinction between bioidentical progesterone, what your body makes is in there, versus the synthetic. Okay? It actually takes away any of the protective effect of doing the estrogen. And it actually upregulates clotting, and so we know that that's part of the problem. So the synthetic was the whole problem in the study. That's where the controversy should be, is that we were giving them the synthetic that is the problem, and that it's still, quote, FDA approved method of hormone replacement therapy. So there are other studies that were done, large studies that show that estrogen started at menopause actually decreased cardiovascular disease. Pretty impressive. They did the memory study. So the other thing they were concerned about is that it increased dementia and memory. Well, again, they used an older age group, and as we know, the Provera, the synthetic, actually increases vascular problems and increases clotting. It does the opposite to your cholesterol and increases that CRP as your inflammatory marker. It increases inflammation. So it does all the opposite things that you'd want to do. We're not surprised. We know all those things about this drug. So late administration, if someone already has Alzheimer's or through menopause, then it wasn't as protective. It's not going to reverse it. But the other studies show that early administration of estrogen showed that the women that went through menopause with balanced estrogen have much lower incidence of Alzheimer's disease on the other end. So that's where it's protective. As much as 83% reduction in lifetime risk of Alzheimer's. That's incredible. And so we're using a natural, a bioidentical hormone back in the body, what your body recognizes, not a drug. So just think, combine that with lifestyle, appropriate nutrition, exercise, community connectedness, those kind of things, you're gonna do great things, more than what any medication could do. So we also look at, for just the HRT users, a 50% reduction in this study, and over 10 years, a 5-fold lower incidence of Alzheimer's disease. So it really should start at menopause, and there's really no downside to indefinite use versus their recommendation that you should only use it for symptoms and stop it as soon as the symptoms go away. So incidence of stroke, and so there was a little bit increased risk, barely statistically significant, but then we knew that if you're going to give them the synthetic, it's going to increase your clotting risk and inflammation, that's going to increase your risk. But we look at the other studies with the bioidenticals, that it improves cognition if you start with the younger women that go through menopause. So there's a critical period when we should be starting that. So there's things to be learned, even though we don't necessarily agree with some of their conclusions, there are things to be learned that we should not ignore. Okay? They try to make this conclusion that there was a connection with causing Alzheimer's or dementia, but there's really not if we look at the population. Okay. Cancer. Let's go back to the colon, 37% reduction in colon cancer. And even in their own study, there was a slight reduction in breast cancer with the estrogen only arm. So where's the culprit? You add in the synthetic progestin and it increases breast cancer. Then there's some question that the incidence of cancer, when they identified it, that these cancer cells were probably present before the study, but they picked them up at the time that you would expect for the doubling time for cancer cells. So progestin is the culprit. It increases growth, increases blood clots, and just by adding the synthetic in, increase your risk of breast cancer. Okay, 8 times over baseline. Progestin is not progesterone, but repeatedly they lump those together. So if you read, even like on the Mayo Clinic website, they're supposed to be highly academic, and they are. I mean, I really think that's a great resource, but on that area, they're not educated and they don't make a distinction, and they haven't seen the literature when we look at what they write about. Osteoporosis, and this is very important if we look at the overall health effect of what we're doing as well. So they didn't really look at younger women, but overall fractures were reduced significantly. And oh, by the way, also estrogen helps to improve arthritis and also protects against the loss of cartilage. We know that it does it for the skin too, right? Skin smoother, right? That can, you know, I don't know if you're on estrogen or not, but you know, it really helps to increase the collagen in the skin. So you'll think about it after you talk. So osteoporosis, so great radicular fracture, but if we look at osteoporotic fractures are more common than heart attack, strokes, and the cancer combined. Okay, and a 2-year mortality from a hip fracture is going to be 50%. So if we look at just the mortality impact of doing hormonal balance, that it actually decreases mortality just from that standpoint more than from the other perceived risk all combined. That's amazing. So that's looking at it from a more public health standpoint, which I'm surprised they didn't. So we know that in their study they didn't extrapolate to the younger women, that they actually did show that the estrogen alone was beneficial. They used synthetics. So then ACOG comes out with their guidelines, shortest time, and you shouldn't use it to prevent the disease. But that's crazy considering all the evidence that's out there for disease prevention. But the other experts say if you're on it, don't change it, and that actually stopping it can accelerate bone loss and can cause more problems, accelerate cardiovascular disease. So many problems that come up with deficiency, so many different areas, not just for menopausal symptoms. There's so many different areas for not only quality of life but disease risk that this is important. So then of course the symptoms, obviously. So many times this is why people come. The same is true for men, but this is just a tip of the iceberg. Because anytime I hear hormonal symptoms at the beginning of that, that's just a tip-off for so many other potential medical problems. So what are the benefits of therapy? So beyond just the symptoms of menopause, improving your cholesterol profile, improving your metabolism, reducing clotting factors, better glucose control, weight control, insulin levels. And what they've actually found that the estrogen really acts as a vasodilator, reduces blood pressure, improves flow in cardiac performance, which is very interesting because the same thing happens for men with testosterone. Cool. So, very interesting. So it reduces the risk for all these things from really head to toe, right? From mental, brain, eye, urogenital problems, very important, including inflammation, right? So it's important for what we're going to find is the root cause of much of the chronic disease today is actually inflammation. Cardiovascular disease, everyone is worried about their cholesterol, but it's a combination probably. And the more we research it, maybe less the cholesterol, more the inflammation. That's part of how this works. So it's interesting, this is a recent study, this is 2013, a Yale study, that looked back and said, what is the effect of this decade of preventing women from being hormonally balanced and being an estrogen avoidance? So they figure that up to 91,600 premature deaths in women this decade because of estrogen avoidance due to that study. Amazing. So, and basically they feel like that's related to cardiovascular disease. So essentially the estradiol is inhibiting the atherosclerosis, the cardiovascular disease. Isn't that amazing? I thought, wow, why has no one ever looked at that before? Well, they have. So in 2009, they went and looked at that, and he did a cross-sectional study, 28% reduction in mortality in menopausal women who replaced sex hormones. Not only that, the quality of life, which they often ignore. Can you imagine? So, I mean, as a woman, I would be insulted that they do all these things, and then they come down to the bottom line and go, yeah, quality of life, it does improve that, but don't do it. Well, you know, that's a very important consideration. That's a very important consideration and a very personal decision for even women that maybe have had some other risk factors, whether they've had cardiovascular disease or cancer for them personally. And I can't make that decision for them. I can only show them what the risks and benefits are. So what do you do? Well, it really does start with, you know, healthy lifestyle. That's really the first place to start with it. And that can help you manage the whole disease risk ahead of time, and that might be why some women do much better going through menopause than others. So exercise, diet, stress management. And we got to use caution. We got to select our patients appropriately when these issues exist, and we've got to go in with eyes open and not just discredit this from the very beginning. And when we give estrogen and progesterone, and not with or without a uterus. So it's common thinking today still that if you don't have a uterus, you don't need progesterone. But progesterone, you have the progesterone receptors all over your body. Very important for all these things. So we do it in the correct route, the correct doses, and I still believe in lowest effective dose. These are very powerful substances. It's as safe as we can do it, but we still want to do lowest effective dose.
Can I ask a quick question?
Sure.
About my mom is 78 years old, and she was on Premarin for since 35 because she had a hysterectomy. And she decided she didn't like what she heard, so she decided to reduce her amount, and she was doing it every 4 days. And then she went to go get her prescription last month, and oh, by the way, they just quadrupled how much it costs for no reason. I mean, and she's like $600 or something ridiculous. And she can't really afford it.
Yeah, she can afford Bioidentical.
Yeah, so I initially I said, you know what, well, why not check Olestrin, which is a Bioidentical cream.
Right.
But what I didn't know, and I must have missed this in class, is why is it that because she doesn't have a uterus, they told her she didn't need progesterone? I didn't.
The big concern for them is protecting against uterine cancer. So estrogen is stimulating for growth, and so they give a progesterone or progestin to regulate that so you don't continue to get uterine thickening, which, so everybody agrees that that's true. I agree with that. I would, for that reason too. So if you have a uterus, you need progesterone with it. You need to balance that.
If you don't, why?
If you don't, but it's also for, one of the biggest reasons is breast cancer protection.
Okay.
But also all the other good things it does for brain and bone and hair,
So I need to make sure she's.
So she needs progesterone with it, and she needs, at least a true progesterone and not Provera.
Well, I could use my grandmother as a prime example. She was 98 when she passed away, and she pretty much took hormone replacement until she was like 96. And the woman fell down a flight of steps with her walker, and she didn't break a thing.
Wow!
Yeah.
I mean, she never went off it. She was like, it's working. I'm not going to go off it. Now, granted, I probably would have been better if she was on Bioidentical, but she also was told she had really high cholesterol. She said, I'm not taking any of that. And because she was on the estrogen.
And so this actually, Bioidenticals actually help to improve the cholesterol profile as well. So estrogen, we hear a lot of talk about preserving bone, right? So that is important. Progesterone and actually testosterone help to increase bone density. So people don't really talk about that. So estrogen is important for preserving, which helps to preserve bone density, but progesterone actually turns on the osteoblastic cells that actually help to make testosterone as well. The same as in men too. So testosterone in men and women do that. So your bone protection, adequate levels for estrogen, but you also need it for that. And you need to prevent the estrogen dominance as well, which increases can increase your risk for increasing growth in breast cells and uterine cells. Good question. No progestins. It's this. So here's the study with the progesterone for breast cancer. So it increased the risk of breast cancer when they used synthetics, but it reduced the risk if they used progesterone. Okay, so it's a significant difference between the two of those. We also know that just progesterone level in a woman decreases the risk of breast cancer. So the higher the progesterone, the lower the risk. And so there's a couple of different studies that show that out. So the literature's out there, so you need progesterone whether or not you have uterus. So what do? Well, you monitor your symptoms. It's going to be a life choice. Look at your levels. Do all the things that we do normally for our preventive health. Pap smears, mammograms, ultrasounds. If there's abnormal bleeding in a woman, we have to get an ultrasound before we're going to do hormonal replacement therapy. Or if that occurs during the time we're doing replacement, we're going to get an ultrasound to make sure that there's not abnormal thickening or any abnormalities. And then you got to do the lifestyle medicine part with that too. So the hormones will help a lot of things. It won't fix everything. It's a part of the whole approach to health and wellness for the woman. All right. Any questions about the women?
Yeah. go back to my mom who's 78.
Uh-huh.
I couldn't answer this question for her, but she
Uh-huh.
she decided she couldn't afford the estrogen any longer, and she didn't. The doctor she goes to doesn't know anything about bioidentical hormones, so I said, okay, at least get the Olestrin,
Uh-huh.
start with that, and then let's
Uh-huh.
find you a doctor up there. Why at 78 would she be having, like, we are talking horrific hot flashes once she went off of the Olestrin?
Yeah.
Not the Olestrin, the estrogen, her,
Sure.
I mean, she's 78, where,
But it's changing the levels. So she's still, any change of the hormone level, up or down. So
so
even
it
when
went
we're,
from, having, her body was used to it for all
that's
those
right.
years.
So it's at a certain level. So then once it starts weaning off of that, then a change in level causes the vasomotor symptoms.
So the doctor said, oh, well, it'll just go away.
Eventually.
And, yeah, but she's like, I mean, this was, something you could see a 50-year-old, I mean, she was bright red, and she's
Yeah.
like, I'm 78, where's all this coming from?
It's the change in the levels, whether it's synthetic or, and even when going up. So if we see a woman who has very low hormone levels actually coming up, sometimes they get symptoms, hot flashes, night sweats, and so, so then,
Well, she said she went out of the
then
country,
that stabilizes.
and she said in 2 days, it went away, once she took the Olestrin and bioidentical.
Yeah, because she's adding back the estrogen.
Yeah.
So then that
Yeah,
takes care of
she
it.
was just like,
So it's a change in levels, whether it's going up or going down, and the
Mhm.
fluctuation for that. And sometimes even when women are perimenopausal, we're giving hormones to try to plane that out, but the ovaries are still doing surges of hormones underneath that. So you're at a certain level, so sometimes you can still have fluctuations that can impact that as well. And we usually think of estrogen doing that. It can still be with the balance of estrogen, progesterone, and then there's still other things that can contribute to the hot flashes, like adrenal changes and thyroid as well. So there are other things that can contribute.
Yeah, can you do a test that can tell how much estrogen I have?
Mm-hmm. Absolutely. So we can look at the different types of estrogen, and so that's the first thing we do. We look at what are the levels. We generally measure by saliva because we feel like that gives us a more precise measurement. You can measure it in the blood, and we also are going to look at testosterone in men and women, progesterone in men and women, DHEA, and we usually do cortisol levels with look at your stress hormones because all of those impact.
Is saliva also used for men as well?
Uh-huh.
So if he had a blood test and that's how they measured his testosterone, it might not be necessarily as effective.
It's not as accurate depending on also the route of therapy. So when we give topicals, then the saliva really gives us a more accurate level. If they're doing injections, we can do both. We just don't have as a precise level. We use saliva because we feel like that it gives us a tissue level. So even when we do blood, we're calculating what their free testosterone level is. Because testosterone and estrogen, progesterone too, they're bound to proteins that float around in the blood. And so our hormones really, they're not doing their action in the blood, they're doing their action in the tissues. And so the thought behind using saliva is that we get what is more reflective of tissue levels of hormone. And we tend to dose more conservatively with saliva levels and still get good control.
Why do doctors take blood tests to figure that out then?
Because insurance covers for blood.
There you go.
So insurance really drives that.
Yeah, it does. True.
Some insurances were covering for saliva, but not many. And it's really because it's clear that it's a good standard. There's millions and millions of, they've done great studies correlating that. The scales are different. We know what's the scale for men, what's for women. We know the scale of expected ranges for different types of hormonal therapy. So, but that's it. It's driven by insurance.
If your thyroid levels are off, wouldn't that have, and you did a saliva test for hormones, couldn't that really impact the correct amount of hormones you may necessarily need if your thyroid isn't balanced properly? I mean, what comes first? And I'm asking that because I was on the
Right.
Bioidentical,
Mhm.
and it turned out I had leaky gut big time and
Right.
thyroid,
Right.
hypothyroid. So,
Right, those go together.
and so what happened was I had to focus on those issues first because
Mhm.
the Bioidentical was really not, that wasn't that's not what my body really needed at the time. What my body needed to do was heal, and
Uh-huh.
and so.
Well, if you're hormonally deficient, your body needs the hormones.
Right.
Depending on the route, so if you do an oral progesterone, you have a lot of bowel issues and dysbiosis and malabsorption, then you're just not going to absorb the progesterone. And so in that case, we have some people who just don't get their levels up taking oral progesterone, so that we give that topically.
Mm-hmm.
Estrogen should never be given orally. It should always be given topically. It acts differently. Even using estradiol, which is a bioidentical, given it orally, acts differently in the body, creates more inflammation, there's more issues given orally because of the metabolism from the liver. When we give it topically, it goes directly absorbed into the bloodstream.
So Premarin that's a pill, right?
Premarin's a pill.
Yeah. So once
So
again,
that's-
that was really affecting the way.
Yeah, so that will cause GI issues and
Yeah.
dysbiosis because it's
Yeah.
the synthetic, it's the medroxyprogesterone. So that can cause more issues. And so for that reason, many times we give them all topically because there's not good gut absorption. And we know that progesterone deficiency is associated with increased permeability and change in bacteria in the gut. So it's associated with what we call dysbiosis. And so that's part of the problem with trying to heal the gut, is actually stabilize and normalize the hormone and the hormone ratio with estrogen. So it's not just the absolute amount, but it's also balancing. Because you can be technically in a normal range for each, but not be balanced. And so the goal is not to continue with estrogen dominance. You want to make sure that they're balanced in the right ratio. Women really feel best that way. Okay, good questions. The men. All right, Van's been waiting for weeks to get to this part. So here's your list of questions, and if you're answering yes, or you have a friend that is answering yes to some of these things, and you may very well be testosterone deficient. And this is actually this questionnaire has actually been validated in big studies. It's called the Adam questions, and so particularly for libido issues or erection issues, that's a big tip-off for testosterone problems. It's not always just testosterone. Sometimes it can be other things. But, so when you think about testosterone, this is what everybody thinks about, right? You know, this is
That was me before I
testosterone.
lost weight.
Yes, me too. My summer in Jamaica. But so this is what people think about, but it's really important for lots of other reasons. It's lots of target organs. People think that there's only one organ that testosterone targets, right? But it's not just the brain. Lots of other areas where it's very important, you know. So of course the sexual organs, the liver, skin, hair, kidney, bone, blood, very important for us. Testosterone is thought of as the life source hormone, right? Sometimes women feel just as strongly about it as the men about having their testosterone. Don't take away, it's like, well, your testosterone is, don't take, I have some women that come there on high dose testosterone. It's very gradual in getting, weaning them because they like the way they feel with it. It's mostly produced in the testicles, but some in the adrenals, and women also make testosterone in the adrenals and the ovaries. It does protect against osteoporosis. It helps with lean body mass and also prevents man boobs because it helps to regulate growth. But as we age, men and women, we get this, what they call androgynous de-differentiation of the sexes. So in relative terms, women's estrogen goes down, men's testosterone goes down, and then we kind of start to equalize. And so we kind of start looking alike.
No, you're kidding.
So some people say that after a while when you're with someone, you start looking and acting alike. And so
That's
this
my
is
aunt and uncle.
This is a great example
Wow.
of what happens when that happens to you. So you want to prevent that. So testosterone deficiency, we kind of think of it in three ways. Usually people think of it in the sexual function arena, which is many times the reason they come, or the psychological, either they're grumpy, they're depressed, they don't have motivation, which is the reason why their partner brings them. And then there's the physical metabolic. They don't build muscle like they used to, their body composition is changing, they're getting a belly fat. those kind of things. But we know that there's other metabolic things that are going on with that as well. So, but there are other things that can cause it other than just being in andropause or menopause. And so we look for those things too. So that's a part of getting an evaluation for men and women. We look at what are the other medical issues that are occurring here that may be contributors and red flags for other problems. So andropause is really the male equivalent. And it's a reduction of testosterone. And it's many times a more subtle and gradual decline than what women go through. But it can have really long-term consequences. So a lot of times people sense loss of drive. I get that a lot. The fitness is not what it used to be. The workouts just don't get them. And they get aches and pains, which goes along with increased inflammation when we're testosterone deficient. So those are the most common reasons people come with the presenting. But then there is some brain and heart issues that are going on. It's very important for our mental function, memory, focus as well. We know that testosterone deficiency increases our risk of cardiovascular disease. So in andropause, we get a change in our body composition. We increase our fat, we lose muscle, we get anemic, we have fatigue, depression, mood changes, and then we oftentimes see something called IMS, irritable male syndrome. Most of the times they're brought as an intervention by a family member.
Please, yes.
But what is the first symptom of andropause? What do you think that is? Well, what we have found is usually this. Primary sports car in the driveway. See?
Oh.
I was actually researching this today on the computer, and Shelly came in and she was like, yeah. She was very polite. She didn't say anything. She walked out, and I realized she thinks I'm just looking at sports cars. You know, while they're out here working hard, I'm in there just kind of cruising the internet. You know, but no. So
I'm going to keep my Jeep there.
yes, right. So you're no problem. I have my sedan out there. You know, I'm good with that. So sometimes there can be subtle changes in sexual function, and sometimes there are things that, well, the same old thing. You know, as you get that age, you're bound to have some problems. Well, that may be true, but then that's not necessarily something you have to live with. That these are signs there may be something going on, and if not for this reason, for other health reasons. Many times it's a red flag. It's a red flag for a lot of different metabolic issues that are going on. And we know that every metabolic syndrome man I have in practice, they're also low testosterone. And very important that we pay attention. So testosterone starts to decline even in our 30s, so it starts to go down. And then after the age 40, it starts declining about 1% per year. And so that we know that by the time at the age 25 to 75, we lose half of our available testosterone.
Wow.
That's quite a plummet. So we got to pay attention. And this is just a graphic of our general decline of our testosterone as we age. So somewhere at this gradual slope, it's different for everybody, is where the symptoms may start to occur. There are other things, obviously, that can contribute to that. Diabetes is a very common one. Stress. You can have normal testosterone, but have high cortisols and stress, and you'll have symptoms like you have low testosterone. And also toxin exposures can go along with that as well. So what's the data? So why does this even matter? So there is mortality data on testosterone as well, so that we know all-cause mortality is higher in men with testosterone deficiency, just like the studies on women with estrogen deficiency. Isn't that interesting? And there's multiple studies looking at that. There's another one that showed that the lower one-third group of testosterone levels had a 33% increased rate of mortality from all causes. Metabolic syndrome is also associated with that as well. Increase with levels of IL-6 and CRP are inflammatory markers. So the lower the testosterone, the higher the inflammation, the aches and the pains. It's not in their head, right? And that's part of the reason why they have increased cardiovascular disease. This is another study showing the graphics. The purple is normal, intermediate, and low testosterone for mortality. So this is pretty clear. I mean, this is mortality data. Why aren't people all on this? Why is there this whole kind of bugaboo about doing hormone replacement? I like this. So your choice, spend half an hour a day exercising or 24 hours a day dead. It's really true. It's all about lifestyle medicine, right? We make the choice. So testosterone sarcopenia just means loss of muscle mass. So muscle mass goes down, and giving it back, even in the elderly population, it still has effect. So there was this theory before that once you got to a certain age, you didn't make any more muscle cells, right? Well, that's not true. So they showed both increased mass and strength in hypogonadal men given testosterone, or raising testosterone levels. There's a number of good studies doing other things like Clomid, which is a fertility drug that actually increased testosterone levels, or given other things like estrogen blockers, or Arimidex in elderly men, increasing testosterone levels does the same. So however you get there. So erectile function, it's important for it, increases libido, increases something called nitric oxide, which is what makes the blood vessels work. And even if we have to give drugs for erectile dysfunction, it makes them work better when they're. So sometimes it's amazing that people will come, they're already on these drugs, but nobody's really treating their testosterone deficiency for some reason. It's like, well, almost all men with some ED function will have much improvement within 6 months if you normalize their testosterone. And it's also about the brain, right? So what's the most powerful sex organ there is? It's the brain. And so there have been clear studies that show if we can normalize testosterone, it improves memory, executive function, and spatial ability. Reduces your risk of Alzheimer's, and probably part of this is increases cerebral blood flow. So the studies are out there. They can read the same science, right? So part of the reason they think prevents Alzheimer's is it decreases this beta amyloid. So the beta amyloid is just this protein that gets in the cell that's found in Alzheimer's patients. So we're not really sure if that's really the problem. That may be part of it. Maybe that it's just a sign that it's collecting there. It also may be a response to inflammation, which is part of the reason why testosterone probably decreases that. The difference between estrogen studies in Alzheimer's in women and testosterone studies in Alzheimer's in men is that even once they got Alzheimer's, there were actually some studies that showed that they had improved function in men given the testosterone. We know testosterone helps to work in the brain with increasing cognition, brain speed, and focus. So that might be why these people had some functional improvement. And cardiovascular risk. So even when we look at EKG changes and exercise tolerance, testosterone improved that right off the bat. There actually was a study given IV testosterone and it actually improved it right away. There's also some studies that show there's good mortality studies that men post-MI that are deficient in testosterone and thyroid have higher mortality. And I talk to my cardiology friends all the time. How many of them you think that are testing thyroid and testosterone in their MI patient? Well, they're not going to do it because they don't do that. They're not. Then they have to manage their testosterone. Just send them to me. I'll take care of them. I'll make their outcomes better if they just, if we get their testosterone. So this is another study looking at ST segments and time of exercises. So placebo and testosterone. So all along the way, great improvement for the amount of time and for changes in their EKGs. And this was in 1999. So this is not brand new stuff. Testosterone inflammation. Decreases inflammatory factors and improves anti-inflammatory factors, lowers cholesterol. And if you look up there, you see inflammation is involved in all these things: cancer, cardiovascular disease, Alzheimer's, arthritis, neurologic, diabetes. So it's amazing how many things that's touching. So we should be doing everything we can, which is one of the reasons why inflammation is an age accelerator. So it's a central role in cardiac disease. So we know that. So what's the scare? Why are people? So what about the scary music? Dun, dun, dun. Now's the time. Okay. So you told me all these good things. Okay. What's the deal, doc? Well, here's the deal. So multiple studies have shown that it really does increase prostate problems and an ability to avoid giving you benign prostatic hypertrophy. Because everybody worries. We always do the questionnaires about what's your urine flow like and all that. So doesn't seem to be there. It looks like it has little effect on the androgen levels, and that there's no conclusive evidence that testosterone therapy increases the risk of cancer or benign prostatic hypertrophy. That was Basil's study back in 2009. So even back in 2006, Gould did this. He looked at 16 different studies and said, hey, there's no increased risk of cancer in all these guys that are on testosterone for 15-year follow-up. That's pretty good. And then Morgenthaler, the Harvard urologist, he did the whole study again and looked at this and said, hey, he's done the trials and they're not seeing it. And he even took normal people, I don't know how you got them to agree, and did prostate biopsies.
Oh my
They
God.
enrolled in this study and they submitted themselves to multiple prostate biopsies over time. No, he's a smooth talker. Okay.
Yeah.
So there's no compelling evidence to suggest that higher testosterone levels are going to make men at any greater risk for prostate cancer. So what do we do? So this is how we look at it. So there's multiple ways of testing for it. So usually we're doing saliva testing, but we can look in the blood, but we have to calculate their free testosterone. We're always looking at the other factors. I'm looking at their estrogen levels. We're looking at their brain hormones, LH, FSH, looking for other reasons why they may have testosterone deficiency. What's probably coming is blood spot testing, which may be the next best thing to saliva. And actually ZRT, Dr. Zava, who created this, invented the test, they're now looking at being able to do capillary blood spot, which may be the next closest thing to getting tissue levels. Because that's really the holy grail, because that's where the hormones are acting, so that's what we're trying to get at. What's the tissue level? We still look at the contraindications, just like we would for women. So active cancer is going to be a contraindication. So unexplained elevations in prostate nodules, well obviously it's an unevaluated prostate to make sure there is or is not cancer. Breast cancer, high hemoglobin or blood counts. Testosterone stimulates the bone marrow to make blood cells, and so that would be a contraindication. And then of course if they're really sick or they have severe untreated sleep apnea, there's some association or studies that show that testosterone could make sleep apnea worse, particularly in severe cases. So again, we have that discussion. We got to sit down and talk about what's the risk for quality of life. Potential adverse effects, yes, so it can increase your blood, but the thick blood that people worry about, there's never been a case that shows that this has been related to blood clots. So that's the worry about having high hemoglobin with doing testosterone therapy. So, adverse effects, gynecomastia, man boobs are not cool. And usually that's related to the estrogen production from testosterone levels, so you have to give a blocker, which is, bless you, which is why we measure the estrogen level in men as well. Fluid retention, sometimes there can be, that's usually with injections and higher dose of testosterone. Decrease in testicular size, 20 to 30% may notice some decrease because there's decreased stimulation of the testicle once you take over and give testosterone. Decreased sperm count, so that's important because that's some younger men who still want some fertility, and so instead of doing testosterone, we actually have some other ways of stimulating normal production of testosterone. If they have unevaluated prostate with elevated PSA, or this prolactinoma, which could be a pituitary issue, which is why we measure that. So we measure prolactin in all of our men and women. So what do? So just like with the women, we're going to do a metabolic workup. We're going to look at all the other issues that can be related to that. As far as I'm concerned, this is a red flag for all the other medical illnesses that are going on. And we follow levels. Just like in women and men, though, when we start hormone therapy, we follow levels. But how many times when you're given Provera or Premarin, did they ever, one, check your levels in the first place, or check your levels afterwards? Well, with synthetics, you can't really do that anyway, so I guess the point is moot. We give hypertension medicines, we're going to recheck your blood pressure. We're giving cholesterol medicines, we're going to recheck your cholesterol. It's really one of the few areas where why would you start someone on something that you're not going to track and follow? So the premise is that we age because our hormones decline, not the other way around. And that this is optional. We need to look at this as a part of our health-related issue. And that we can use it to head off the premature aging and get back our vitality that we had when we were younger. Very good.
Cool.
Thanks for your attention.
Yeah, very good.
Thank you, very good. That was very